Hello everyone, my name is Minu and my topic of presentation is effect of constraint-induced movement therapy on gait. So CIMT is designed to reduce functional problems in more involved upper extremity. We constrain movements of the less involved arm, usually with a sling or a mitt, for 90% of the waking hours. We intensively induce the use of the more involved arm. The main thing to remember in CIMT is concentrated and repetitive training of the more involved limb, usually 6 hours per day for a 2 to 3 week period. The compliance of the patient for restraint, the training schedule, and the required intensity are some important issues to be considered. Now, modified CIMT is less intense treatment than the traditional CIMT, meaning it takes less time, but it involves the same principles as CIMT. To understand the principles of CIMT, we need to understand the development of learned non-use. So learned non-use results when a child attempts to use the involved limbs unsuccessfully while showing increased reliance on the stronger or the uninvolved limb in all the activities. So because of the unsuccessful motor attempts, the child fails to do the movement and hence the behavior is suppressed and hence there is learned non-use of the limb. Secondly, if the child is not able to use the involved limb, there is compensatory behavior of the alternate limb and hence the less effective behavior is strengthened, leading to learned non-use of the limb again. So when there is learned non-use of the involved upper extremity, CIMT increases motivation to use the affected limb, and hence there is positive reinforcement when the patient is able to use the affected limb, and further practice and reinforcement repeatedly leads to use-dependent cortical reorganization, and hence the learned non-use is reversed. The theoretical foundation includes neural plasticity and cortical reorganization. So the clinical bottom line is that CIMT research has always been focusing on upper extremity functions, the basis being repeating functional movements in the involved upper extremity leads to development of new motor plans and hence increased retention of the task. The retention of motor performance is enhanced through the use of task repetition. But my clinical question here is if CIMT has secondary effects to improve gait when you improve the upper extremity functioning. Given that the motor system functions as a dynamic system, we can hypothesize that improvements in upper extremity functioning resulting from CIMT would positively influence lower extremity functioning. The basis can be the mechanics of walking, where we all know there is an interdependent relationship between all four limbs. The interdependent relationship results in a 2:1 face-limb coordination ratio when we are walking slow, so 2 arms swing to each leg stride, and with the emergence of 1:1 ratio in face-limb coordination as the gait speed increases. Hence, when there is decreased arm swing, it leads to decreased stride stride length and a decreased velocity. So upper extremity function does affect the lower extremity function. So the first article is about gait characteristics of children with hemiplegic cerebral palsy before and after modified CIMT. So there were 12 preschool children, 11 males, 1 female with hemiplegic CP between 2 years 6 months and 6 years 2 months of age. They were given CIMT for 5 consecutive days, 6 hours per day. Pre and post intervention data was collected based on the temporospatial aspects of gait. This session was provided at Medical University of California. The authors say that this was the only on-site organized program in the state to provide constraint therapy for children with CP. The constraint was given using a resting hand splint covered by a soft puppet glove. There were two groups, with two different modified CIMT camps at two different times in a year, but they all had same activities. Now, this two different times in a year, they haven't described what two different times it is. There were two testing conditions, so they were tested with AFO and they also walked bare. The outcome measures were the gait right walkway to measure the walking velocity, cadence, step length, base of support, step time between the steps, single and double support times. The data were analyzed using repeated measures with the generalized linear mixed model. What they found was the heel-to-heel base of support decreased, velocity, cadence, step length of involved extremity increased, the time of double support decreased, single limb support increased or remained same. So all these results basically concluded that modified CIMT can increase the stability and improve the overall gait pattern. Just an overall critical appraisal of the article. Some of the strengths of internal validity included that it was a very highly organized program, so that was controlled. They used age-matched velocity reference to be consistent. The threats to internal validity included that there was no control group and there was no long-term follow-up, since it was just a one modified CIMT experience. The strength to external validity was that it was conducted in 2 times of the year, so I was assuming maybe it is like a winter and a summer session, so where we consider the nerve conduction velocity due to cold into picture, where if there is decreased nerve conduction velocity, that would affect movement. So since they have considered 2 times of the year, they have covered both those conditions. The threats would be small sample size. The male to female ratio was not equal, like it was 11 males and 1 female, but in kids, to check gait characteristics, I was not really sure if that would be a threat to external validity based on the gender. Some strengths of the statistical validity included that they used the appropriate repeated measures with generalized linear mixed model. The threat, although, was that there was no statistical power to test the difference in subject grouping based on the age or on the use of AFO and without AFO. The second article studied the secondary effects of CIMT on spatial temporal parameters of gait, balance, and functional locomotor mobility in children with CP. 16 children from 4 to 12 years of age were included in the study. It was a 3-week summer program called the Camp Open Arms for Children with Hemiplegia. It was conducted in July at Children's Specialized Hospital in New Jersey. Participants were tested on first and last day of the program. The splint used was a long arm fabric covered fiberglass splint. For their activities, they included age-appropriate bilateral and unilateral upper extremity functional activities while standing, sitting, and walking. The duration was 3 weeks for 5 days per week for 6 hours per day. So there were 3 outcome measures. The first was the standardized walking obstacle course. to measure the functional locomotor mobility. They used the pediatric balance scale to measure balance, the gait right goal system to measure the velocity, cadence, and number of steps. What they found was that the spatial temporal parameters of cadence and velocity differed significantly, with 12 subjects displaying a faster cadence and 10 subjects displaying a faster velocity. They used a Wilcoxon signed rank test for all the pre-test and the post-test measures. There were no changes noted in the standardized walking obstacle course and the pediatric balance scale. The strengths of internal validity included that the patients were tested in a quiet and structured environment. Although it was not a randomized controlled trial, there was random assignment to the order of the test. To ensure anonymity, codes were assigned to the children for blinding of the testers. Age-appropriate activities were included in this as well. The threats included that there was no control group and there was no long-term follow-up. External validity threats included that since it was a summer program, as I said earlier, there might be some effect of climate, and that reduces the generalizability of the study if it would have been conducted maybe in a colder climate, considering the nerve conduction velocities being slow in cold, it might have been different. Again, structured environment can be a threat for generalizability. The strengths of statistical validity included that when they realized there is a deviation from the normality in the baseline score, they appropriately used non-parametric testing for their data analysis. So the clinical application for all the physical therapists would be to understand the importance of interlimb coordination while walking. Basically, CIMT has always been a focus of research for occupational therapists since we are considering the use of upper extremities more. But physical therapists need to further investigate the intensity and protocol to enhance the gait functions while using CIMT on upper extremity. Basically, we need to work as a team with the occupational therapist and the physical therapist being together, working towards the betterment of the patient's condition. Thank you.